Thank you, Christopher. We will begin the session of lamellar keratoplasty, and I would like to introduce our first presentation. Dr. Rajesh Sinha, who will discuss anterior lamellar keratoplasty for corneal opacity.
Thanks a lot. I'll be discussing with you about automated anterior lamellar keratoplasty. Very specific topic. It started with the advent of the microkeratome and the artificial chamber and this console. And then it was used, and it is still being used for superficial corneal dystrophies, superficial opacities, scars, granular dystrophy, band-shaped keratopathies, fluoral degeneration, trachomatous keratopathy. And in these conditions, it works quite well. So on an artificial chamber and with the microkeratome, we run, and that's how we create the donor lenticule. And then in a host, again, we use the suction ring, and with a microkeratome head, we first look at the cornea with the anterior segment OCT, see how much depth is the disease, about 250, 300, whatever. Depending upon that, we can use the head, and that's how we debulk or reduce or remove the opacity completely or near completely, so that we can provide a similar thickness of donor lenticule and provide a good outcome. You can see the scar has been mostly removed and the visual axis area is clear. You can also combine it with a picoemulsification in cases of, say, bad trachomatous keratopathy. In such a case, with the help of microkeratome, you can clear the visual axis quite significantly. And once you clear it well, then you can see how well it looks now. And once you remove the opacity, you can, in order to improve visualization, then you can go ahead and complete the cataract surgery and place the intraocular lens under direct visualization, the very good visualization, and then replace this removed tissue with a donor lenticule of similar thickness. And that is how we perform the anterior lamellar keratoplasty in these cases. And with the automated keratoplasty, the interface is very good, and that's the advantage. The interface is very regular. We did a study long back at RP Center, and that was comparing automated keratoplasty versus manual keratoplasty, and we found out that it took less surgical time. There was early epithelialization, there was better contrast and glare acuities, and early visual rehabilitation was seen. And better visual outcome, better contrast, better glare acuity. You can see here that in case of lattice dystrophy, this was done when you see that the opacity is involving anterior stroma, mostly in lattice we do talc these days. Case of a multiple corneal foreign body which is involving superficially, you can cut the superficial corneal tissue. Scar, wherein you can reduce the density of the scar. A healed keratitis, again, you reduce. The idea is that you reduce the bulk, you reduce the density of the scar, so that the scar becomes faint or it goes away completely, and then you can place another lenticule created by the microkeratome. So that's how you get a very smooth interface, and the visual quantity and quality is much better. And with a manual lamellar keratoplasty, sometimes you get to see a debris, sometimes you can have irregularities, sometimes you can have interface haze, and that is there is the advantage of using the microkeratome in creating a smooth surface. This is a study which we published long back in the year 2012, automated keratoplasty in trachomatis keratopathy. Now, if the opacity is involving superficially up to 200 microns, in such a case, we can leave it sutureless. So this is a donor lenticule that is being fashioned on microkeratome. As you can see here, this is again a trachomatis keratopathy, a couple of nodules which are being manually removed. When there's a nodule, it's always better to remove it manually and do a manual keratectomy and then use a microkeratome. You can see how clear it has become. A little bit of cataract is there, so it's always better to remove the cataract, place the intraocular lens. And once you place the intraocular lens, you can inject air for some time in order to have a nice, well-formed chamber, and then put a donor lenticule of the same size and of similar thickness. And then you dry the edges. And once you dry the edges, you put fibrin glue at the edge and then place a bandage contact lens. So the fibrin glue actually keeps it for a few days. We keep an extended period of bandage contact lens we prefer using it for 3 weeks actually, where we can change after 10 days and we can put another bandage contact lens. So that is what we do in a sutureless anterior laminar keratoplasty. Conditions like a granular dystrophy, it works very well because most of the opacities are up to say 200 or 250 microns. So you can, even if it goes beyond 200, you can debride the epithelium and then cut 200, have a 200 micron tissue. And what we have noticed that in a 200 micron tissue, we don't require a suture, it stays well. And this, I guess the concept came when we had a free cap in LASIK. And then that cap was when placed and put a bandage when the bandage contact lens was placed, it remained there. So that was the basic idea of doing a salve. You can see this granular dystrophy, how nicely it's a sutureless keratoplasty, no opacity is there. It's almost cleared. You can see 1 or 2 opacities here in the peripheral part, which doesn't carry much significance. So it works quite well. A case of a post-LASIK epithelial ingrowth wherein this patient was observed because the epithelial ingrowth was in the periphery and that resulted in flap melting. So in such a scenario, there are 2 options. Either you can amputate the flap, debride, remove the epithelium completely, and you can leave it like that. But if there is availability of corneal tissue and if the cornea surgeon is handling it, it's always better to replace the tissue of similar thickness and of similar size. And this similar thickness and size can be determined by anterior segment OCT. We can get to know that what was the flap thickness, and that is how we in this case, the epithelial ingrowth is being debrided and the mitomycin C will be used. And then donor lenticule is being positioned and of similar size and thickness. And you dry the edges. You dry the edges and then put fibrin glue at the edge and then put a bandage contact lens, and it works quite well. Femtosecond assisted anterior laminar keratoplasty works very well, particularly if you go deeper, the irregularity in the interface is there. But in a case of a sutureless keratoplasty, when you are using up to 150, 200 microns, in such a case, what we get is that we get a very nice vertical edge. So edge-to-edge apposition and the risk of epithelial ingrowth is absolutely insignificant. The apposition is much better if you use a femtosecond laser. So this is how we do it. And we lift the flap, we remove it, and then we take the patient to the routine from the femtosecond laser. The patient has been shifted to the routine OR. As you can see, this is the superficial part is quite hazy. It is a case of a healed keratitis with some vascularization. That is why there's bleeding. So now this tissue is being removed, will be placed in position, and you can see the edge is quite vertical, and a little bit of irregularity was there because of the scars. So I'm trying to smoothen it. We shouldn't use too much of burr, otherwise that will also cause scarring. So we have to be very judicious in its use in the interface on the stromal surface. And then we can place the lenticule, and there's very nice edge-to-edge apposition if you use femtosecond laser for dissection. So in conclusion, automated anterior laminar keratoplasty is quite safe. It provides good result because the interface is good, so the quantity and quality of vision is better in comparison to a manual anterior laminar keratoplasty. Thank you very much for your patient listening.